Welcome to today's deep dive, everybody. We are going deep into the world of medical coding and specifically EM coding.
EM coding, that's evaluation and management coding.
That is evaluation and management coding. Now, if you're listening to this, you are probably prepping for your medical coding exam and want to really understand these guidelines.
Especially according to the Absolute Medical Coding Institute.
Exactly.
Yeah.
So we want you to feel confident tackling those exam questions and also real-world scenarios you might encounter. And speaking of the Absolute Medical Coding Institute, we have linked their MCG manual down in the description. So, yeah, go check that out.
Definitely those guidelines are so essential for coders. And the MCG manual with the facts to remember, or FTRs, they simplify those CPT guidelines.
You really do. They make it
Right.
so much easier.
Yeah.
All right, so before we go too far, can you give us a quick overview of what EM services actually are?
Well, let's imagine a patient walks into an urgent care clinic with like a sudden onset of severe abdominal pain. Everything that provider does to assess and manage that patient falls under EM services.
Okay.
Like taking the history, performing the exam, ordering tests, making a diagnosis, treatment plan, all of that.
So it's like the whole picture.
The whole picture.
It's not just a specific procedure.
Exactly. It's managing the patient's health during that specific encounter.
Okay, that makes sense. So let's say you are facing, a stack of charts and you need to assign the right EM code. What are some of the key factors that you're looking for?
Well, you got to consider the who, what, where, and when of that encounter.
Who, what, where, and when. I like that. Okay.
So the who is the patient new or established. What type of visit is it? Is it an office visit, hospital admission, or consultation? Where did it take place? Hospital, clinic, nursing home. And then when that gets into the time spent with the patient, or if there were multiple services on the same day.
Okay.
And of course, we can't forget medical decision making, or MDM for short.
MDM, that seems like a big one.
Uh,
Can you explain why it's so important in EM coding?
It really is the heart of EM coding.
Okay.
It reflects how complex that medical decision-making process was for that encounter. Did the provider need to analyze a lot of data, consider different diagnoses, or, manage a high-risk situation?
Okay.
The more complex those things are, the higher the EM code.
Okay, so it's not just about, the time spent. It's,
Right.
the level of thinking involved.
Exactly. A quick follow-up for a stable patient is going to have a much lower MDM than, say, diagnosing a new patient with a really complex condition.
That makes sense. All right, let's break down some of these key components a little bit further. Let's start with the who, the patient. New versus established. Why is this distinction so important when it comes to EM coding?
Because it comes down to the level of service provided. A brand new patient needs a much more comprehensive evaluation than an established patient. You have to gather their entire history, establish a relationship. It's much more involved. So those codes for new patients are generally going to have higher values than the established patient codes.
That makes sense. So how do you determine if a patient is new or established? Is there a rule?
Yeah, there's the 3-year rule.
The 3-year rule?
If the patient hasn't seen a provider in the same specialty and subspecialty at that same practice within the past 3 years, then they're considered new.
Okay.
Otherwise, they're established.
3 years. Got it. So what if a physician is covering for a colleague?
Ooh, that's a good one.
Yeah. Does that change anything?
In those cases, you still code as if the unavailable physician had performed that service.
Oh, okay.
And also remember that advanced practice nurses and physician assistants are considered to be within that same specialty and subspecialty as the physician they're assisting.
Oh, that is helpful to know.
Yeah.
All right, let's dive a little bit deeper into MDM. You mentioned that it has these 3 key components. What are they and how do they all fit together?
So the 3 components are problem addressed, data, and risk.
Okay.
So the problem addressed considers what the patient is presenting with. Is it a simple, straightforward problem or, a chronic condition with lots of different factors?
Okay.
Then data refers to the amount and complexity of information that was gathered and analyzed. Did the provider review lab results, order tests, consult with specialists?
Okay.
And then risk assesses the potential for complications.
Right.
This includes, how complex is the problem, what's the patient's overall health, and the possibility of serious outcomes.
So the more complex the problem, the more data you have to look at, the higher the risk, the higher the MDM level.
Yes,
Okay.
exactly.
Oh.
And that higher MDM level means you'll choose a higher EM code to reflect that complexity.
Okay. I'm starting to see the connections here. And,
Yeah.
sometimes you have to factor in the time spent with the patient as well, right? Tell me about time-based coding.
Right. Sometimes the time a provider spends with a patient is the determining factor for picking the correct EM code.
Okay.
But there are some specific rules.
Okay.
The time documented has to be at or above the time listed for that code.
Okay.
And it should reflect the total time on the date of the encounter.
So if a provider spends a lot of time with a patient, even if the MDM isn't super complex, it could still justify a higher code.
Absolutely. You might have a situation where a patient comes in with what seems like a straightforward issue, but as the provider digs deeper, they uncover, a whole web of factors that need a lot of attention and time. In these cases, the time spent accurately reflects how complex the service really was, even if the MDM itself isn't at that highest level.
That's interesting. Okay, so what happens if a patient has multiple encounters on the same day? How do you code for that?
Okay, so it depends. Did those services happen in the same place or different settings?
Okay.
So if it's the same setting, you combine all the visits and you'd use either the highest MDM or the total time spent that day to determine the code. But if the services were in different settings, like say an office visit followed by a hospital admission, then you would report separate EM services.
Oh, okay.
Just be careful not to count the same time twice.
Okay, so this sounds like where those modifiers 25 and 26 come in.
Right, exactly. Modifier 25 is used when you have a significant and separately identifiable EM service on the same day as a procedure. It signals to the payer that, hey, this EM service was above and beyond what's normally included in that procedure code. And then modifier 26 is used when you have a separate report for the interpretation of tests.
Yeah.
And it indicates that the provider spent that additional time and expertise interpreting those tests.
So it's all about making sure that the coding accurately reflects all the work that was done. All right, let's move on to the specific EM service categories outlined in those FTRs.
Yeah.
And we'll start with office or other outpatient services. These seem like the most common ones.
They probably are. They cover a wide range of outpatient settings, including doctor's offices, urgent care centers, and ambulatory surgery centers. And as we discussed before, you have your new patient codes 99202 through 99205,
Right.
and then your established patient codes 99212 through 99215.
Okay. And those can be used for like consultations and transfers of care too, right?
That's right.
Okay.
They cover those scenarios.
Okay.
And here's a fun fact.
Okay.
Sometimes you might even use outpatient service codes in an emergency department setting.
Wait, really? Why would that happen?
It's not typical, but sometimes an ED service location might be used for the convenience of the physician or qualified healthcare professional.
Okay.
And in those cases, you would actually use the outpatient service codes
Interesting. Okay.
instead of the usual ED codes.
Okay. That is definitely something to keep in mind. All right, let's move on to hospital inpatient and observation services. What makes these codes stand out?
So these codes deal with the unique aspects of inpatient and observation care. You've got different types of codes, each designed for a specific scenario.
Okay.
You have your initial services. Those are used by the admitting physician for that very first encounter.
Okay.
Subsequent services are for follow-up care or consults during that same stay.
Got it.
If a patient is admitted and discharged on the same day, you'd use the Combined Admission and Discharge Services Code.
And then lastly, there are discharge services codes, which cover discharge day management, including all the services provided on that day.
So it's like a step-by-step guide through the patient's entire hospital stay.
Exactly. It's all about accurately reflecting those nuances of inpatient and observation care.
I like it. Okay, what about consultations? They seem pretty straightforward.
Well, they can be.
Okay.
But with consultations, you got to remember the 3 R's documentation requirement.
Okay, the 3 R's.
Request, recommendation, and report.
Okay.
You need documentation showing a request for the consult, a recommendation from that consulting physician, and then a report back to the referring physician.
So are the codes different for like inpatient versus outpatient consultations?
Yes, they are. Outpatient consultations use codes 99242 through 99245, while inpatient consultations use 99252 through 99255.
Okay.
And another key point is that you can only use an inpatient consultation code once per admission.
Got it. Good to know. Okay, let's shift gears and talk about emergency department services. I imagine they have their own special set of rules.
They do. What's interesting is that the time spent with the patient and whether they're new or established doesn't actually factor into the coding. The focus is entirely on MDM.
Really?
Yeah. How complex was that medical decision-making in managing that patient's condition?
So it's all about like the urgency and complexity of that situation.
Right. The ED codes 99281 through 99285 are designed to reflect that urgency and that level of decision-making that's required to address those situations.
Okay, I see why MDM is so critical in that environment. What about critical care services? These seem especially intense.
They are. Critical care codes 99291 and 99292 are for those critically ill patients that require that constant attention and a lot of complex interventions. These are time-based codes. 99291 is used for the first 30 to 74 minutes.
Okay.
And then 99292 for each additional 30 minutes after that.
And there's a whole range of services that are included in those codes, right?
Oh, yeah. Things like intubation, managing ventilation, vascular access, even invasive monitoring.
Wow, that's a lot. We've covered so much ground already.
Yeah.
Let's take a pause here, and we will come back to explore some of the specialty-specific guidelines in part 2 of this deep dive. Okay, so let's jump back into our EM coding deep dive. We were just about to get into some of the specialty-specific guidelines.
Yeah. It's fascinating how these codes are really tailored to all these different healthcare settings.
Right.
So like, for instance, nursing facility services.
Right.
These codes specifically address the care provided to residents in long-term care facilities.
Okay.
They have a similar structure to those inpatient codes we talked about, with separate codes for initial, subsequent, and discharge services.
Okay, so it's a more focused approach.
Exactly.
Okay, what about preventative care visits?
Preventative medicine services, they're all about those essential well visits and checkups focusing on preventative care.
Okay.
And what's interesting is that they're determined by the patient's age
Okay.
and whether they are new or established.
So a yearly checkup for a 25-year-old would be coded differently than a wellness visit for like a 65-year-old.
Exactly. And it's important to remember, if any immunizations or additional procedures are performed during that preventative visit, you would need to report those separately using modifier 25.
Okay. It's all about the details. So
Yep.
what happens when a provider goes above and beyond and spends way more time with a patient than a typical EM service would allow for? How do you code for that?
That is where prolonged services codes come in.
Prolonged services. Okay.
These codes are specifically for those instances where a provider spends significantly more time and effort than what's typically covered.
Got it. How does this connect to the bigger picture of patient care and coding accuracy?
Well, these codes are essential because they ensure that the provider is fairly reimbursed for their time and their expertise,
Okay.
and they accurately reflect that intensity of care that was
Yeah.
provided to that patient.
It sounds like EM coding is constantly evolving, especially with all these new models of care that are emerging. What about services that aren't face-to-face, like telehealth?
That's a great question. With the rise of telehealth and remote care options, there's a whole set of codes specifically for non-face-to-face services.
So a virtual consultation would have a different code than an in-person office visit.
Absolutely.
All right.
For instance, you have codes for telephone services.
Okay.
As the name suggests, these codes are used when an established patient has a consultation with the provider over the phone. Then you have online digital EM services,
Okay.
which are specifically for patient-initiated communications using online platforms.
It's incredible how coding is keeping up with all of these advancements in technology.
It really is. And we can't forget about remote physiologic monitoring.
Okay.
These codes are used when a provider remotely tracks and manages a patient's physiologic data.
Oh, wow. Okay.
Things like their heart rate, blood pressure, or blood sugar levels.
Technology is definitely changing how we approach healthcare. But even with these remote services, accurate documentation is still critical, right?
Absolutely. Just like with any EM service, you need that clear documentation to support those codes.
Right.
The core principles of medical necessity, accurate documentation, and that appropriate code selection are essential, whether it's delivered in person or remotely.
All right, we've covered a lot of ground here with these EM services and coding guidelines. As we wrap up, what are some key takeaways you want our listener to remember, as they prepare for their exam and their future career in medical coding?
Well, it's important to remember that the FTRs that we've been discussing are incredibly helpful, but they are a simplified version of the guidelines.
Right.
The full MCG manual is your go-to resource for that complete guidance.
MCG manual.
Yeah.
Every coder's best friend.
Yes. And it's crucial to stay updated on any changes or revisions to the codes.
What else?
Practice, practice, practice.
Yes.
The more you work through those coding scenarios using those guidelines, the more comfortable and confident you'll become.
So mastering those fundamentals and then getting hands-on experience. Okay, any final words of wisdom as our listener embarks on their coding journey?
Remember, you are not alone. There are amazing resources out there to support you, like that MCG manual we talked about, professional organizations, and online communities. Don't be afraid to reach out, ask questions, and never stop learning. EM coding is a challenging field, but it's incredibly rewarding, and you play a crucial role in ensuring accurate and ethical billing practices.
Those are great words of encouragement. And to our listener, thanks for joining us on this EM coding deep dive. We hope this episode has provided you with a solid foundation and boosted your confidence as you prepare for your exam and your career in medical coding.
We've talked a lot about, the current state of EM coding.
Yeah.
But I'm curious about the future. With telehealth becoming more and more popular and technology constantly evolving, where do you see EM coding heading? That's a great question, and it's one that a lot of people in healthcare are thinking about as technology changes the way we deliver care.
Yeah.
The coding guidelines are going to have to adapt too.
Right.
So, we might see new codes created for telehealth services that don't even exist yet, or changes to existing codes to better capture the nuances of virtual care.
Yeah, it sounds like coding is always going to be evolving.
It is.
It's exciting, but it also keeps you on your toes.
It does. It definitely does.
Before we wrap up, is there anything else that our listeners should keep in mind as they're, kind of diving into the world of medical coding?
The most important thing is to remember that you are not alone.
Yeah.
There are so many resources available to help you.
Right.
We've talked about the MCG manual, professional organizations, online communities of coders.
The whole community.
It is. And don't hesitate to reach out,
Yeah.
ask questions, and never stop learning.
Right.
EM coding is a challenging field, but it's incredibly rewarding.
Yeah.
And you're playing such a vital role in ensuring accurate and ethical billing practices.
Those are great words of encouragement.
Thank you.
And to our listener, thank you for joining us on this deep dive into EM coding. We hope this episode has provided you with a solid foundation and boosted your confidence as you prepare for your exam and your career in medical coding.